All right. Good evening, everybody. I want to thank you guys for joining us for the first part of our Dear Lectureship series. Tonight we have Dr. Christopher Wenger to speak on food as medicine, managing your lipids to avoid heart disease. At the end, we will allow time for questions. You can feel free to use the Q&A at the bottom, or you can use the raise hand. Once we get to that point, we'll open it up and Dr. Wenger will be available to answer questions for a few minutes at the end. Thank you.
All right. Am I good to go, Sam?
You're good, Dr. Wenger. Thank you.
Oh, fantastic. Awesome. Well, welcome, everybody. Great to have you here. I'm excited to give this talk to kick off Heart Healthy Month, right? So a real quick blurb about me for those of you who don't know. I was raised in Lancaster County and joined WellSpan in the fall of 2020. I feel honored to serve my new community here in York. I'm board certified in cardiovascular medicine with subspecialty board certifications in adult echocardiography, nuclear cardiology, and clinical lipidology. Boy, it's a mouthful when I say it like that. I proudly serve right now as medical director of preventive cardiology at the WellSpan Heart and Vascular Building at 30 Monument Road in York. And I really work to diagnose and manage metabolic and genetic cholesterol issues using nutrition wherever I can leverage, and also counseling and drug therapy. I'm also an active member of the Physicians Committee for Responsible Medicine and serve on the Nutrition and Lifestyle Work Group for the American College of Cardiology and the National Lipid Association. We get to write pretty cool papers on diet and such. So before we begin, I wish to thank the Deal family personally for their endowment that makes this lecture possible. The Millard G. Deal Cardiovascular Lectureship Endowment was established in 1996 through a bequest left to WellSpan Health by Millard G. Deal. Mr. Deal's generosity has enabled WellSpan Heart and Vascular to establish an annual cardiovascular educational program for our community for free. This is the first of 4 lectures for the month of February. We will be recording this presentation, so a link can be provided to those who miss it and wish to view it. Also, please note that Zoom participants may submit questions through the Q&A function, and I will address each and every one of them at the end of the presentation. So for disclosures, I actually don't have any relevant financial disclosures for this particular topic. I put some other disclosures for some other things below, but that's really beyond that. No one takes me out, to dinner, corporate carrot, big broccoli. They haven't called me in quite a while. So, so I do this completely without any paid consultation or anything like that. So let's get started. And a quick point I want to make is that I will be discussing atherosclerosis. For those of you who don't know that $2 word, I'm really referring to coronary artery disease or blockages or plaque, all the same thing here, okay? For this talk today, atherosclerosis is artery blockage, hardening of the arteries, however you want to know it as, but it's all the same stuff here. So with that, let's get started. The Inner Heart study was a global multi-center study involving more than 15,000 patients with a first heart attack and 15,000 people who had no symptoms that served as the control group. And this study, this huge study, revealed that 90% of risk for having a first heart attack can be attributed to 9 modifiable risk factors. The 9 factors that are threatening our lives include cigarette smoking, high blood pressure, diabetes, belly fat, yep, I said it, stress, lack of daily fruit and vegetable consumption, lack of exercise daily, and of course, high cholesterol. However, in order to have atherosclerosis, or again, coronary artery disease, must you have high blood pressure? Do you have to be a smoker or have diabetes? Or be overweight or have a hard family history of coronary artery disease? The answer is, of course, no. So then what do you really have to have? Well, there's only one absolute in atherosclerosis, and that is, in order to have it, cholesterol must enter the intimal layer of an artery wall. The cholesterol is then taken up by macrophages. These are very big cells. They create foam cells, and then what follows is an inflammatory mediated cascade of events on the wall surface and inside the wall itself. Simply put, atherosclerosis cannot exist if cholesterol is kept out of the artery wall. And it's all the retention theory model of how this all behaves. We won't get into the science of it per se tonight, but we will talk about a lot of data proving this. So Dr. William Clifford Roberts, Executive Director of the Baylor Heart and Vascular Institute and longtime Editor-in-Chief of the American Journal of Cardiology, contends and I tend to agree with them, that atherosclerosis has a single root cause, and that is cholesterol, and that the other so-called atherosclerotic risk factors are contributory at most. In other words, a person could be stressed, overweight, smoking diabetic couch potato, but if their cholesterol was low enough for their life course, there may just not be enough cholesterol in the bloodstream to infiltrate the artery walls and trigger atherosclerosis, like we just talked about. Thus, the only absolute prerequisite for a fatal or non-fatal cardiac event, such as a heart attack, is an elevated cholesterol level. As he states, if the blood LDL cholesterol is less than 60 milligrams per deciliter, or the blood total cholesterol is less than 150 milligrams per deciliter, there's no evidence, with extremely rare exceptions, that these other risk factors actually cause atherosclerosis. Studies dating back to over a century ago successfully reproduced atherosclerotic plaque in animal models, particularly in herbivores such as rabbits and monkeys. However, no researcher has ever produced atherosclerosis experimentally by increasing arterial blood pressure or blood glucose or sugar levels. No one has produced atherosclerosis experimentally by stressing animals or by blowing smoke in the faces of rabbits their entire lifetime. It's all about the cholesterol. It was not appreciated until recently that the average blood cholesterol level in the United States, the so-called normal level, was actually abnormal, accelerating vascular disease and putting a large fraction of our population at risk for our #1 killer. That's cited as one of the reasons the cholesterol controversy lasted so long. It was an unwillingness to accept the notion that a very large fraction of us actually have unhealthfully high cholesterol levels. What we're often calling normal cholesterol levels may actually be our terminal cholesterol levels. The optimal LDL cholesterol is 50 to 70 milligrams per deciliter. Accumulating data from multiple lines of evidence consistently demonstrate this is where a physiologically normal LDL cholesterol levels would be. That appears to be the threshold above which atherosclerosis and heart attacks develop. That is what we start out with at birth. That's what our fellow primates have. That's the level seen in populations free of the heart disease epidemic. In fact, the current epidemic of atherosclerosis may well exist because our contemporary lifestyle has pushed our current LDL cholesterol levels to twice as high as physiologically necessary. Interestingly, modern humans are the only adult mammals, aside from a few domesticated animals, because they eat what we eat, with a mean LDL cholesterol over 80 milligrams per deciliter and a total cholesterol over 160 milligrams per deciliter. Whereas the optimal LDL cholesterol appears to be about 50 to 70, the average LDL cholesterol among Americans today is 125 milligrams per deciliter, which is inferred by this total cholesterol level of 208, as you see at the bottom of the page. We can also look at all the large randomized controlled cholesterol lowering trials. This graph shows progression of atherosclerosis versus LDL cholesterol. More cholesterol, more atherosclerosis. But if you draw a line down through the points, you can estimate that the LDL cholesterol level at which there is zero progression is down around an LDL cholesterol of 70. You can do the same with the studies preventing heart attack. Zero coronary heart disease events might be reached down around 55. And those who have already had a heart attack and are trying to prevent a second heart attack might need to push their LDL cholesterol levels even lower. The point I wish to make here is that atherosclerosis is endemic in our population in part because the average person's total cholesterol is 208, which again corresponds to an LDL cholesterol of approximately 125 milligrams per deciliter. This is twice the normal physiologic levels. This figure is from the famous Framingham study. The physicians online today know the Framingham study. It's the, following people from Framingham, Massachusetts for decades, their kin and next of kin. And this is how we've actually developed over time cardiovascular risk factors for heart disease. So this figure is taken from the famous Framingham study, and it reveals the cholesterol levels of the people who had no coronary artery disease, no atherosclerosis. And here, as you see coming in, is the cholesterol levels of those with coronary artery disease. The curves are hardly any different, right? Because practically everybody's cholesterol was too high. Pretend for a moment that everyone was a smoker, right? Imagine if everyone smoked 20 cigarettes a day. If everybody smoked, then clinical studies, case controls, cohort studies, et cetera, would lead us to conclude that lung cancer was a genetic disease. And in one sense, that would be true, right? As all of us smoking, some smokers would get cancer while others smoke their whole lives and don't get cancer. But if everybody smoked, we'd never know that smoking was a risk factor to begin with. And we'll be coming back to that slide shortly. It's well accepted that coronary atherosclerosis is a chronic progressive disease that begins early in life and slowly progresses over decades before symptoms actually arise. However, the average age in cholesterol-lowering drug trials is 63 years, and therefore people have already been exposed to a lifetime of abnormally high circulating cholesterol. So no wonder pharmaceutical therapies, medications like statins, typically reduce cardiovascular disease risk by an average of only 25 to 30%. The evidence to support LDL cholesterol as a cause of atherosclerosis is overwhelming and includes meta-analyses of genetic studies, prospective epidemiologic studies, Mendelian randomization studies, and randomized controlled trials. The evidence base includes 200 studies involving over 2 million participants with over 20 million person years of follow-up and more than 150,000 cardiovascular events. So it seems reasonable to assume that if lowering cholesterol later in life can help, then keeping LDL cholesterol levels low earlier in our lives might prevent atherosclerosis in the first place. But let's not just assume. If you look at young men aged 18 through 39 and follow them up for 34 years, cholesterol levels, even when you're young, predict long-term risk of heart disease and death. Men in their 20s and 30s who've had a total cholesterol under 200 have a substantially longer estimated life expectancy, about 4 to 9 years or so, than those who have a total cholesterol over 240. Evidence from observational studies like this one, of course, is vulnerable to confounding factors. Like what else are these people doing that have worse or better outcomes with heart disease? So ideally, we'd have a long-term randomized trial to kind of isolate this. And as it happens, nature may have actually set one up for us. Each of us at conception gets a random assortment of genes from our parents, and some of these genes may affect our cholesterol levels. Just like there are rare genetic mutations that result in unusually high cholesterol, and I see these types of patients all the time. There are rare genetic mutations, far rare genetic mutations, I'd say, that lead to unusually low cholesterol, providing an ideal system to assess the consequences of low LDL cholesterol levels independent of other confounding diet and lifestyle factors. So let me show you what I mean. 1 in about 40 African Americans have a gene mutation that cause underexpression of a glycoprotein called PCSK9. Less PCSK9 means that the liver can clear cholesterol from the bloodstream much more effectively. In fact, studies like this is how we came up with the PCSK9 inhibitors that we use in practice commonly now to lower cholesterol. You know, we're trying to mimic what nature provides some lucky few. So let's look at what happens with these people. So panel A there at the top, you can see that LDL cholesterol goes from up around 130 milligrams per deciliter on average, like we said, it's about 125 in America, down toward more optimal levels. So you see in panel A at the top, the distribution of blood LDL cholesterols among about 3,200 Black subjects who are like the rest of us. We don't have that genetic PCSK9 gene mutation, this loss of function of PCSK9, as we say. Compare this to the bottom graph there in panel A. This shows the distribution of LDL cholesterol levels among 85 Black subjects who have this genetic gift I'm discussing. And you can see how the blue shaded bars are moved and migrated over to the left. Their LDL cholesterol is by far lower than everybody else who's on the top of the panel A. Now, this group didn't eat healthy to get there. It's just in their genes. More than half had high blood pressure. There were many smokers and diabetics, yet those with genetically low LDL cholesterol still had a significant reduction in coronary heart disease, even in the presence of all those other risk factors. How significant? How much less heart disease? How about 88% of heart disease gone? In fact, one subject of the 85 subjects with this genetic advantage actually developed coronary heart disease, and he was reportedly obese, had marked high blood pressure, he smoked, and arguably the reason he got heart disease is his lipoprotein A was above the 95th percentile. So again, it came back to cholesterol. Lipoprotein A is the silent killer. We won't talk about this talk, but it's worth a Google. This They were born with it. They didn't just start. So remember, the point I want to make here is exposure to abnormally high cholesterol levels in the blood over time is what causes coronary artery disease to appear and grow in our arteries. We cannot alter time. I heard Pfizer's working on that, but we cannot alter time, but we can lower cholesterol exposure in the bloodstream. And this is not hypothetical, guys. Here we see a cross-section of coronary vessel at baseline on the left, compared to repeat imaging 2 years later after being on statin therapy during that time. The bottom two panels illustrate the same cross sections, but with coronary artery plaque measurements superimposed. You can see that the kind of the yellow color there is measuring the atheroma or cholesterol-rich plaque in the artery wall. The left panel, top and bottom, is the patient, the people at baseline, and then 24 months later after 2 years of statins, you see the right. And you can see that there's a reduction in the amount of plaque. Clearly, that yellow section has shrunk over those 2 years with cholesterol therapy. We know from multiple studies using intravascular ultrasound, this is a fancy imaging technique we often use in the cath lab, we see that reducing LDL cholesterol levels to around 60 milligrams per deciliter can actually facilitate marked regression or reversal of coronary artery disease. You're probably thinking, wait, what did he say, reversal? Let me repeat, achieving an LDL cholesterol to roughly 60 milligrams per deciliter or lower, and the body can delipidate or remove soft cholesterol plaque out of the coronary artery walls. This is heart disease reversal, folks, and it is possible. In returning to the Framingham diagram, instead of getting our total cholesterol, as shown here, from high risk to high risk, it's better to achieve low risk or even no risk. Here's where I would be expected to review the current drug therapies on the market and all the hot stuff coming down the pike in the next couple of years. However, I'm going to tackle something much more difficult and less widely known and recognized, and that is food is medicine, dietary medicine. Yes, we're going to go there right now. So let me begin by providing you the punchline. The best way to prevent a heart attack, to prevent even atherosclerosis in the first place, is to start at step number 1, prohibiting the development of cholesterol-rich atheromas or plaque, which is a result of having too many cholesterol particles in our bloodstream. Although genetics do play a role, in some cases, the vast majority is an issue with our diet, our lifestyle choices. And this is what causes a huge exposure to cholesterol over years. And this is how atherosclerosis both starts and progresses over time. So what makes high cholesterol in the bloodstream with regards to the diet? Well, there's 3 main things we're going to talk about today. Trans fat. It's found mostly in processed junk food and animal products. Saturated fat, which is found in, again, mostly processed junk, meat, dairy, and to a lesser extent, even eggs, but mostly that's cholesterol. And that's the third thing, dietary cholesterol itself, meat, dairy, and especially eggs. And then if a patient happens to replace some of these items with whole plant-based foods that are high in soluble fiber, then a patient's cholesterol will drop like a rock. And allow me to explain. The most updated USDA dietary guidelines were published about a year ago. They're the 2020-2025 guidelines. In case you don't know, every 5 years, the USDA publishes their dietary recommendations for Americans. So when you look at the overall dietary patterns of Americans, it should come as no surprise why the prevalence of high cholesterol and thus coronary heart disease is pervasive in modern society. This graph is taken from the USDA guidelines. The purple striped bars above that middle line show the number of Americans consuming foods at or above the recommendations. However, the blue bars below the dark line show the percent of the population below the recommendations. The center line is the goal or limit. For most, those represented by the dark blue section of the bars can improve their dietary patterns by shifting toward that center line. Here we see that more than 80% of Americans are not eating enough vegetables or fruit. Now, more than half of Americans are eating plenty of grain, but look closely. The vast majority of these grains are refined grains. Think simple flours like white bread, pastas, pretzels, tortilla, and most breakfast cereals, etc. Americans eat very little whole grains. You know, the grains that are really dark, brown. You can't crumple them up and throw them at your friend like you can with Wonder Bread or something of the like. These grains are full of fiber. With regard to protein, Americans eat more meats and far less in the way of seafood. Then when you look at some other things too, you see that, looks like there's a delay here, guys. Sorry. There you go. Looking at sugar, fat, and salt, we see the majority of Americans consume too much added sugar, saturated fat, and just about everybody seems to be consuming too much salt. The majority of patients can combat cholesterol through lifestyle changes, mostly through diet. But for those who can't or won't change their lifestyle, there's always the option of prescription medication. And don't get me wrong, such drugs work very well, particularly in those with established heart disease, those with genetic conditions, and those who just don't want to change their lifestyle, right? It helps to cover the gap. But they also carry significant side effects at times and cost, right? So dietary changes can improve so much more than just cholesterol and offer no negative side effects whatsoever. The NCP, the AHA, the WHO all back a heart-healthy diet and recommend reduction in trans fat, saturated fat, and dietary cholesterol, all while working to increase dietary fiber. And so we're going to break through these one by one. Let's start on the one that's easiest to pick on, trans fat. Those on ketogenic diets and vegan diets can all agree on this. Trans fats are bad, increasing one's risk of heart disease, sudden cardiac death, and even diabetes. With regard to blood levels of cholesterol, trans fats have a completely unfavorable effect. They increase LDL cholesterol, VLDL cholesterol, triglycerides, and lipoprotein A. And if that's not enough, they also decrease HDL cholesterol and decrease LDL particle size, which is associated with a slightly greater atherogenicity than the large LDL particle size. Trans fats are basically only found in one place in nature, and that's animal fat. The food industry, however, found a way to synthetically create these toxic fats by hardening vegetable oil in a process called hydrogenation, which rearranges their atoms to make them behave more like animal fats. So back to the USDA guidelines for a moment. Most of America's trans fat intake is traditionally come from processed foods containing partially hydrogenated oils. We call this industrially processed trans fat. However, as of June 2018, partially hydrogenated oils are no longer generally regarded as safe, or what we call GRAS, G-R-A-S. Therefore, these fats are no longer added to foods. This means that now more than ever, Americans are getting a significant portion of their trans fats through the consumption of animal products such as meat and dairy. The question is, are animal trans fats as bad as processed food trans fats? After all, the US has removed the addition of trans fats to foods, but what about the animal products we continue to eat? A compilation of randomized interventional trials found that they both increase LDL cholesterol, they both decrease HDL cholesterol, and so, of course, both types of trans fats will increase the LDL to HDL cholesterol ratio, which is not a favorable outcome. So all trans fats cause negative effects, irrespective of their origin. The researchers suspect that removing natural trans fats from the diet too could prevent tens of thousands of heart attacks. But unlike processed foods, you can't just remove trans fats from milk and from meat because trans fats are already there naturally. According to the official USDA nutrient database, which hasn't been updated in a while, it looks like cheese, milk, yogurt, burgers, chicken fat, turkey meat, bologna, and hot dogs contain about 1 to 5% trans fats. Now, consuming a few percent of calories from trans fats isn't a problem, right? Well, as it turns out, the most prestigious scientific body in the United States, the National Academies of Science, concluded that the only safe intake of trans fat is 0. In their report condemning trans fats, they couldn't even assign a tolerable upper daily limit of intake because any incremental increase in trans fatty acid increases coronary heart disease risk. The bottom line is that all sources of trans fat should be minimized, not just to improve cholesterol levels in the blood, but to lessen what excessive amounts of cholesterol exposure over time causes, and that's atherosclerosis. The trans fat in processed foods can be banned, and adhering to the current dietary guidelines to restrict saturated fat, like we're going to talk about, kind of, which is found in meat and dairy as well, would kind of automatically cut trans fat intake as well. So let's discuss saturated fat, because they're close cousins. The American Heart Association recommends reducing saturated fat to no more than 5 to 6% of total calories. Assuming a 2,000 calorie a day diet, that's no more than 120 calories of saturated fat daily. That is a small amount. I mean, one KFC chicken breast or 2 pats of butter and 2 cubes of cheese, and you're done for the day. No more meat, dairy, no eggs. So they are in effect saying that 90% of the diet should be free of saturated fat containing foods. So that's like the American Heart Association saying, okay, 2 meals a week can be packed with meat, dairy, and junk, but the entire rest of the week should be unprocessed plant foods. That's how stringent the new recommendations are. Where did these consensus guidelines to dramatically reduce saturated fat come from? Well, from literally hundreds of metabolic ward experiments, which means you have total control over the diet being investigated. You can experimentally change their level of saturated fat intake however you want and see the corresponding change in their cholesterol levels. And the results are so consistent, you can create an equation, what's called the famous Hegstead equation, where you can predict how much a patient's LDL cholesterol will increase based on how much saturated fat they eat. So if you wanted to increase your LDL cholesterol, maybe have it go up by 50 points, all you have to do is eat about 30% of your calories from saturated fat. When you plug in the numbers, the change in cholesterol shoots right up as predicted. And the experiments, of course, match the predictions. This figure shows that for each 1% increase in energy from saturated fat, serum LDL cholesterol concentration increases by anywhere from 1.2 to 1.7 milligrams per deciliter, based on a few studies from a few different laboratories here. The USDA dietary guidelines reveal the #1 source of saturated fat in the American diet is, in fact, dairy. Dairy has replaced red meat as the #1 vehicle for saturated fat in the American diet. We are eating too many sandwiches filled with processed meat and cheese. And remember that cheese is an example of high-fat dairy. And then we're treating ourselves after that sandwich with a dessert laden with more high-fat dairy. Think ice cream, cakes, cookies, pies, and cream, etc. I know, I'm a great person to have over for dinner. I also want to point out the amount of saturated fat in animal-based oils, as well as the tropical oils. Note that a few plant-based oils, such as coconut oil, palm kernel oil, and cocoa butter, are even higher in saturated fat than animal-based oils, such as lard. If using oils at all, consideration should be given to the oils higher in monounsaturated fat. Think olive oil, think avocado oil, think canola oil, especially for your higher temperature cooking, if you use oil at all. We at the Wenger home, we use salt-free or low-salt veggie broth to slick our pans. Saves a lot of calories. Alas, we have the conclusions from the most prestigious scientific body in the United States, the National Academies of Science. They conclude, with regards to saturated fat, that an upper level is not set for saturated fat because any incremental increase in saturated fatty acid intake increases coronary heart disease risk. So we have randomized clinical trials, controlled interventional experiments, our most robust forms of evidence. No wonder there's a scientific consensus to decrease saturated fat intake. So let's talk about dietary cholesterol. This is always a taboo subject, isn't it? If you look at dozens of studies pulled together covering hundreds of subjects, we find that blood cholesterol concentration is clearly increased by consuming dietary cholesterol. In other words, putting cholesterol in your mouth means putting cholesterol in our blood. And there is some nuance, so let's go over that. However, because there's a plateau effect, you can basically max out on cholesterol absorption. After a certain level of intake, it's just another match to the fire. The average dietary cholesterol intake of the average American is just short of 300 milligrams per day. If say 2 jumbo eggs are added to their diet, their serum cholesterol raises only modestly, about a 7% increase. However, for those people really trying to eat healthy, those same 2 eggs could shoot their cholesterol up by over 20 milligrams per deciliter, and even more so in those who are what we call hyperabsorbers of dietary cholesterol. Heart disease has been described as a postprandial or after meal phenomenon. This is actually one of my favorite slides because this is such an important point, guys. Let me repeat that. Heart disease has been described as a postprandial or after meal phenomenon. That means we don't develop artery plaques in our body when we're fasting. But the problem is you kind of have to eat to live, right? So we have to be cautious. So what happens after a meal that includes high dietary cholesterol, such as eggs, such as in this study? Well, first, here's what happens to the level of fat and cholesterol in our bloodstream for the 7 hours after eating a meal with no fat, no cholesterol. And you see there's hardly any change at all. But now a meal with fat and more egg yolk, triglycerides shoot up and blood cholesterol shoots up. I hope that's loading for you guys. There you go. There it goes. That's kind of bad data for the egg company, right? It's not good for the egg sales. So what could you design, or how can you create a study to hide this inconvenient fact? Well, what if you only measured fasting cholesterol levels in the morning, right? We do that all the time. Everybody gets a fasting cholesterol panel in the morning. We're used to that. Maybe 7 hours after supper. You wouldn't see a big difference between those that ate eggs the night before and those that didn't, right? Measuring fasting cholesterol is appropriate for measuring the effects of drugs suppressing our liver's cholesterol production, but not appropriate for measuring the effects of dietary cholesterol. After a cholesterol-laden supper, look at what our arteries are being pummeled with all night long. And think about the day. How many hours are there between meals, really? Maybe 4 hours between breakfast and lunch. So if we had eggs for breakfast, we'd get that big spike. And by lunch, start the whole cycle of fat and cholesterol in our arteries all over again. Our body never gets a break. Most of our lives are lived in a post-meal state. And this shows that the amount of cholesterol in those meals, they actually used eggs in the study. So the amount of egg in our meals makes a big difference when it really matters after we've eaten, which is where we spend most of our lives. Sorry, guys, having a problem here with the pointer. There we go. I hope you guys are hearing me and seeing me okay, because it's the slides here are getting really slow and choppy, but we're almost done. Thanks for hanging in there. I hope this has been enjoyable so far. Another thing sometimes the egg studies do, when you read about eggs being healthy and such, you have to be careful too. Other than waiting 7 hours, they will also enroll people with really high baseline cholesterol, because again, as we're passing through the slide again, it's just another match the fire, right? If your cholesterol is already through the roof, adding eggs will not make a bit of difference. It's like wanting to study lung cancer risk in smokers